Right now is the session for triple negative breast cancer, early stage triple negative breast cancer, Pembrolizumab and keynote trials. And here with us, Professor Dr. Peter Smith, and he is the lead Center of Experimental Cancer Medicine, Barts Cancer Institute. A big round of applause for Professor Dr. Peter Smith, sir, for his presentation for the management of early triple negative breast cancer. He will be with us in virtually, and he is now connected. Yeah, we can see, sir.
You can hear me as well. Thank you for your kind invitation, also to my friend and colleague Sakula. I'm sorry I can't be out there personally, but I hope we can still connect here virtually very well. If you can't hear me, shout at me. Otherwise, I assume you can hear me and just keep talking. Now, triple negative breast cancer I think, is the subtype where we have made most progress in the last 5-6 years. We were behind. We had poor outcomes 6-7 years ago. We have introduced 3 or 4 different treatment strategies in that time. Each of them, taken on its own, reduces the risk of recurrence by 40 to 50%. And as a result, if you treat patients well, their outcome is now substantially better than it used to be. Now, one of the questions we always get in clinic, does everyone need chemotherapy? And probably the majority of patients do. If you look at the data from Predict NHS, T1N1 has about a 7 to 10% survival benefit. T2N0 about, and this is pre-immune therapy, about a 7 to 10% survival benefit. And these have always been patients we routinely considered for neoadjuvant therapy. With the smaller tumors, it gets a little bit more difficult. But if you look at this analysis, even the 1 to 2 centimeter node negative tumors have about a 7% survival benefit, half a centimeter to 1 centimeter, 5% survival benefit. And the guidelines say give those patients do surgery first and give chemotherapy afterwards. But we are increasingly offering these patients also neoadjuvant treatment. And the reason for that is we can then tailor the chemotherapy and possibly de-escalate some of the chemotherapy because not all patients may need a full AC, carboplatin, paclitaxel. The only group where it's a bit of a question mark is the T1A and NOD patients. And the reason why I put that question mark in there is if you look at a different analysis, these were data from the American SEER database. So these are not randomized data, to be very clear. And there may as always be a slight bias in how patients were treated. But what is very clear is that the benefits of chemotherapy may be smaller than we thought in the very small cancers, T1A and T1B. And so I think we still need to look at the overall risk of patients and other factors before we decide on treatment. An interesting observation was the role of the immune system in this. And we're obviously going to talk about immune therapy in a minute, but this was already an early hint. And in Holland, many years ago, it was apparently standard practice that patients with tumors, regardless of age, smaller than 2 centimeters would not get any chemotherapy. And so there are 15-year follow-up data of patients with triple negative breast cancer who were chemo naive, but they looked at the outcome depending on whether they had TILs, tumor infiltrating lymphocytes in the tumor or not. And as you can see, the outcome of patients, these are T2N0 patients with low TILs, is unfortunately shockingly low without chemotherapy, as you can see here. And as these were young patients, these are chemotherapy, these are cancer-associated deaths, unfortunately. But on the other hand, if you look at high TILs, that's only a small group of patients, 20% of patients, their outcome is really fantastic. And so that can be a marker that could possibly guide us in the future if prospectively validated and confirmed. Now, if we just speak briefly about stage 1 triple negative breast cancer, what would you do? Which regimen would you choose? And you know, there's a whole range out of there. We can give 3 months of treatment. We can give 4 to 6 months therapy with or without anthracyclines, with or without taxanes, with and without platinum, dose stents or not. And I think the factors that can possibly help us with the decisions, of course, age, size. There's clearly a difference between 4 millimeters and 19 millimeters. Grade, lymphovascular invasion, We use a lot Ki67 because it tells us whether it's more or less aggressive until possibly after the data I showed you. This is just an overview of some of the regimens that are currently being used. And it goes from AC-EC, and I wouldn't use that anymore, to TC, which I don't think is an optimal regimen in TNBC. And we tend to use Dostans AC, and then followed usually by paclitaxel carboplatin. But one of the things I would like to mention is in those smaller tumors, I also quite like to give paclitaxel carboplatin as preoperative therapy. If you have a 12 millimeter tumor, you may just give paclitaxel carboplatin for 12 weeks, see whether the patient has a complete response, and therefore spare them from anthracyclines. And that's for me one of the major advantages of considering neoadjuvant therapy also in those smaller tumors. So going to the overall way we treat triple negative breast cancer, the historic way of doing surgery first and then chemotherapy is going gradually away. We are now giving chemotherapy before, and the old studies that showed there's a similar outcome, I think, have been superseded by other evidence. And the benefit from giving chemo first has always been we can downstage the tumor. I will share with you some data on the axilla in a second, which I think is even more important than the downstaging in the breast. But of course, most importantly, we can divide patients into two groups. A group of patients who does amazingly well, who has a pathological complete response, and those patients do not need further therapy. And then there are patients who have residual disease and have a high risk of disease recurrence, where we at the moment trying to improve the outcomes with chemotherapy or some of the antibody drug conjugates. I promised you I would talk about the downstaging of the axilla, and I think that's really, really important. So this is a study with just over 500 patients, bit mixed, HER2 positive, triple negative. But if you look at on the left side, the clinical node status before neoadjuvant therapy. So you see N0, clinical N0, N1, and N2 and 3. And then the right side, you see the pathological response in the lymph nodes, and in the green box in patients who had a complete response in the breast, and in red in patients who had still residual disease in the breast. And I think that's really interesting. So if you have a patient who is node negative at the beginning, has a complete response in the breast, 96, 97% of patients will have also a path CR in the lymph node, expectedly. So that's a group of patients where we can de-escalate. But also if you have patients who have a node positive in the breast before neoadjuvant therapy, who are, as you can see in the green box, have a complete response in the breast, most of them will have a complete response in the axillary lymph node. And these are patients where we reduce now the surgery there with TAT and take that lymph node out to assess this. Even in patients with N2 and N3, still nearly 90% are node negative if they respond in the breast. But of course, if you look to the right side, if they don't respond in the breast, they have a high risk of metastasis. And I think this stratification will be something we should consider a little bit more, and that allows us to escalate and de-escalate the local management in the axilla. The key question for many years is, if you give neoadjuvant therapy, can we improve the outcome of patients after surgery if they have residual disease with further chemotherapy? And the answer is very clearly, yes, we can. We can do this, and this was a pivotal study by the Japanese-Korean group, with actually a really not very effective chemotherapy. Capecitabine, excuse my words, in breast cancer is a pretty rubbish therapy, but nevertheless, in these patients who had preoperative chemotherapy, those days without immunotherapy and platinum, and then had residual disease and received capecitabine for 6 months, you can see a substantial reduction in the risk of death, nearly halving of it, and therefore that has become standard of care until we have more effective treatments. But also in patients with germline and BRCA1 and BRCA2 mutations, the Olympia trial, the PARP inhibitor, olaparib, given for a year in those patients, again reduces the risk of recurrence by nearly 50% and should be standard of care for patients. Now, what's the role of platinum? And you've seen me show this slide probably before. This is the old slide. We knew the path CR rates in neoadjuvant therapy without platinum are now around 35% only. And we have learned if we add a platinum to there, as you can see here in 4 randomized trials, the path CR rates go to around 50-55% consistently. So about a 15% absolute improvement in path CR rates. Well, why has it taken us so long to make platinum standard of care? One of the reasons was that these studies were small, they weren't necessarily powered for event-free or disease-free survival. Although, if you look at the bottom of the slide, you can see there was a benefit, at least a signal in all those trials, and in some of those trials that was significant. The really pivotal study, again from the Korean group, that has really, for me, now answered the question once and forever was the Pembrolizumab trial presented at ASCO in 2024. And this is a trial powered for event-free survival. The primary endpoint is event-free survival, not path CR. It was done before the immune therapy data were out there. So these days, these patients would get immune therapy because they were lymph node positive or had tumors larger than 2 centimeters. 860 patients, 1-to-1 randomized AC taxane or AC taxane plus platinum. And the treatment could be given as neoadjuvant therapy, which was about 2/3 of patients, or as adjuvant therapy, which was about 1/3 of patients. And there was about 11% BRCA mutant patients. Now, if you look at the primary endpoint, event-free survival, a clear, a significant, an important improvement in event-free survival, hazard ratio 0.64, clearly that determines the standard of care. And it is improving, it is translating in an overall survival benefit, not quite yet in terms of significance, but you can see if we wait another year or two, this will be significant with hazard ratio 0.65. If you look at the benefit in subgroups, this is seen whether patients are node positive or negative, whether it's given in the neoadjuvant or adjuvant setting, really important, because in the UK we had people who said, I wouldn't give platinum in the adjuvant setting. Now they cannot say this anymore. But also, probably equally importantly, we see that benefit regardless whether patients are BRCA mutant or BRCA wild type. So don't just use platinum for the BRCA mutated patients. Actually, the BRCA wild type patients seem to be benefiting equally. And for those who are worried, look at the right bottom corner, no difference in quality of life. We can give this safely. It's a cheap drug. There's no reason why not to do this. I tend to give carboplatin once a week at an AOC of 1.5. With a bit of experience, that is very easy to give to those patients. Now let's move on to immune therapy, because that is probably the biggest change we have seen in the last few years. And there were various, when we developed immune therapy for breast cancer, there were various concepts we were discussing. We were discussing, and highlighted in green on top, this hybrid concept of giving immune therapy right at the beginning with chemotherapy, but also continuing it in the adjuvant setting. The rationale here was if you start with chemotherapy, where the tumor is really sensitive, you have optimal release of the antigens, and therefore probably an optimal induction of the immune therapy effect. But of course, there was also a consideration whether we overtreat some of those patients. If you look at the other concepts, we try to get a concept off the ground with delayed start of immune therapy when patients don't respond well. Although there were some concerns that if the chemo doesn't work well anymore, do we actually still release antigen and can we launch an immune response? Then if you go further down there, the adjuvant concepts, and that is great from a patient pathway if you happen to take the cancer out. But there has always been a concern. If you take the cancer away, how can you train the immune system, what the target and the enemy is? And I will talk about this in a minute. And then there's the post-neoadjuvant concept, which again, for me, has always had the same concern. Now, there are now 3 phase 3 trials of neoadjuvant chemotherapy and immune therapy. The largest is KEYNOTE-522, which used an optimal chemotherapy regimen, taxane, platinum, followed by ACEC with either placebo or Pembrolizumab, and then continued with immune therapy after surgery, nearly 1,200 patients. The co-primary endpoint, early readout, path CR, late readout, event-free survival. Smaller study in PASSION-03, but only 300 patients, so really, really small, only powered for path CR, And for me, a suboptimal chemotherapy regimen without platinum for the reasons I outlined, and then gave dose-dense AC and unblinded patient at surgery. And then the latest study came out in San Antonio, an attempt to copy Keynote 522, but use a different checkpoint inhibitor, atezolizumab here. So again, taxane platinum first, but it gave the option of 2-weekly or 3-weekly AC and EC, and then patients could continue afterwards. Now, if you look at the two studies that had PathCR as a primary endpoint, you can see very clearly there's a meaningful improvement in PathCR rates of about 13 to 15% in both studies. And I always say that's regardless of what chemotherapy you use. But if you use a less effective chemotherapy, as we see on the right, it obviously starts on a lower level. So immune therapy will add a benefit whether I give it to a less effective or more effective chemo, but it will obviously can't compensate for the less effective chemotherapy. The more important endpoint going forward is not just the PathCR, but it's also whether we cure more patients. And so we looked at event-free survival, and these are the updated data from a few months ago, now with 6 years follow-up. 6 years is really important in triple-negative breast. 5 years is actually important. As you know, with triple-negative breast cancer, we see 60–70% of recurrences in the first 2 to 3 years, and that's when you see those curves dropping very, very early and very quickly. And then we see about 90–95% of events in the first 5 years, so very few additional events in year 3 to 5. And then the curves tend to plateau. So what this confirmed now is that we reduced the risk of recurrences by about 35%. Hazard ratio is 0.65. If you look at the absolute events, it's about nearly a 10% difference in recurrences between patients treated with immune therapy or patients who did not have immune therapy. And these data are definitive and are not going to change because of the nature and the biology of triple-negative breast cancer. Should everyone get immune therapy? And we did a lot of work on different groups. If you look at the obvious group, PD-1 positive patients, on the left side, you see again the PathCR data. And what's interesting there is PD-1 positivity is a predictor of response to chemotherapy. So in red, you see the chemotherapy-treated patients, low PD-1, 30% PathCR, high PD-1, nearly 60% PathCR. But interestingly enough, the extra benefit given by immune therapy on top of that seems to be the same whether patients are PD-1 positive or negative. And then if you look at the right side in the orange box, these are the event-free survival data, exactly the same whether tumors are PD-1 positive or negative. Why is that? That's in contrast to what we see in metastatic disease. Our hypothesis is that the tumors are very dynamic and plastic, and if you give immune therapy, we have data, if you give immune therapy to a PD-1 negative tumor, about nearly 70% of tumors turn PD-1 positive in only 2 or 3 weeks. So this is a very dynamic marker in early disease, whereas in metastatic disease, it all is much more settled. And therefore, do not use PD-1 to select patients for neoadjuvant therapy. But of course, you need to do this in the metastatic setting. Are there any clinical groups that do not benefit? Or we looked at stage 2, you see an 8% delta, hazard ratio 0.59. If we looked at node-negative patients, 8.5% delta, hazard ratio 0.56. And even the smallest, T2 and node, so small cancers, no lymph node involvement, nearly 10% better event-free survival, hazard ratio 0.49. So there isn't a group we should deselect. And we presented some biomarker work in San Antonio, which was interesting, but ultimately utterly unhelpful because we couldn't identify a group, we couldn't identify a predictor, and therefore would recommend to consider practically all patients for immune therapy. The final bit here, which I think has been really critical, is the overall survival data, which I presented a few months ago at ESMO. And that is showing that we reduce the risk of death by 34%, a definitive result. So not giving immune therapy now means patients have a much smaller chance of being alive after 5 or 6 years, and therefore that is now definitively a standard of care. How does immunotherapy work? Does it just work through better response? Is there benefit from immunotherapy beyond the response? And the answer is yes, there is. So these are the data for event-free survival, depending by path CR. So you see the two top curves, in red chemo alone, in green chemotherapy and immunotherapy, depending on whether patients had a path CR. And the way I interpret these data is there's a 4% better outcome if a path CR was achieved with the help of immunotherapy, meaning, and we know the same for HER2-positive disease, the quality of the path CR can be different depending on how it has been achieved. The second thing I take out of it is you look at the two lower curves here. These are the curves of patients with residual disease, where you would argue the treatment didn't work optimally. But actually, you have a 10% in absolute terms, hazard ratio 0.72, better outcome if patients received immunotherapy. And that suggests to me that it clearly changes the tumor biology and works beyond just inducing a response. So the implications are, if you see a path CR benefit, of course that translates into long-term benefit. But if you do not see a path CR benefit, patients may have still derived a benefit from that agent, from immunotherapy. Now, the spanner in the works a little bit was this trial called GEPA-DUCE, and I showed you this design earlier. That is this similar trial to Keynote 522, but this time using atezolizumab. And the trial was presented in San Antonio and is completely negative. Now, we can argue, is it completely negative? You see a separation of the curves. That is very clear, but the hazard ratio is 0.8, and therefore the trial is very clearly negative after an adequate follow-up. If you look at some of the subgroups, what's interesting, there seems to be less of a benefit in patients who are node negative, but also, and I haven't put a red box there, there's a question mark whether patients who have 2 weekly therapy may have less of a benefit compared to patients who have 3 weekly, which is what we used in Keynote 522. Ultimately, atezolizumab in this trial did not work, whereas pembrolizumab did work and didn't just show up event-free survival, but also overall survival benefit. What about the side effects we see with immunotherapy and here with pembrolizumab? So these are the side effects during the chemotherapy phase. And green is, again, the patients treated with pembro. Red is placebo, obviously in combination with chemotherapy. And you can see the most common side effects are very, very similar because they are driven by chemotherapy and are not changed through the addition of immunotherapy. But if you zoom in and take out the most common side effects and look at the possible immune-mediated side effects, what sticks out is hypothyroid function is much more common. With immunotherapy, easy for us to manage. If you look at the rest, severe skin reactions, that's relatively rare. And then the big fives, endocrine, skin, and then you already go to colitis, hepatitis, and pneumonitis. And they're in the 1% to 2% range and can actually occur without immunotherapy as well. So what's really critical for immunotherapy is that the team knows what they're doing. If you see the patients every 2 months, you will run into trouble. If you see the patients relatively frequently, then immunotherapy is straightforward to manage. What about adjuvant immunotherapy? In those patients where we accidentally took the tumor out, does it make sense to give immunotherapy after surgery or started after surgery? And the answer is, unfortunately, no. If you miss the boat, you miss the boat. And this is the Alexandra study, again with atezolizumab, taxane, AEC, and patients who have primary surgery. And if you look at the data, invasive disease-free survival, including PD-L1 positive patients, absolutely no signal there. So critical for all the surgeons in the room, do not take triple-negative breast cancers out until you have spoken to your oncologist, because you take away the survival benefit in terms of being able to give post-operative therapy with capecitabine or olaparib, but also take away the survival benefit with immunotherapy because it does not work once patients have their tumor taken out. An interesting little study. I was part of that, and I'm still trying to work out what I make of the data. So this is a trial where I said for many years I'm not sure it will actually show up any positive result because preoperative chemotherapy then patients with residual disease received immune therapy or not. Now, it's a small trial, and that's the caveat. But if you look at the outcome here, and the left side primary endpoint disease-free survival, it looks like there's a separation of the curves. It's not significant, so the trial is negative. And if you look at the number of events, 81 versus 91, it's a small study, but possibly there could be a signal, and we need to keep an eye on this. So where are we, and where are we heading? Standard of care for early triple-negative breast cancer is now very clearly in stage 1 disease. We would not use immune therapy. You can do primary surgery or neoadjuvant chemotherapy, especially in the larger stage 1 tumors, which would be my personal preference. And that's why you see one decreasing, the other one increasing. Stage 2 and 3, clearly the standard of care is chemotherapy and immune therapy. And those patients who have apathia, for now, we continue with immune therapy. And those patients who have residual disease, you've got an option. You can give chemotherapy, as you can give capecitabine, you can give olaparib. If they have a BRCA mutation, you can give immune therapy. And you can combine them, which is what I try to do, combine pembrolizumab and capecitabine in those patients. One of the questions just here for the discussion, because it's so fundamentally different. If you have a tumor that's 16 millimeters, clinically initially node negative, but if there was no positive, you would give immune therapy. You can't give immune therapy after surgery. So is there possibly a role, again, for upfront sentinel lymph node biopsy, which we tried to get rid of because it was really not helpful? But maybe here it could guide our decisions to give immune therapy or not, and we can discuss which of those factors we may take into consideration. Where are we heading? Where's the research going at the moment? There's a number of trials we're doing. In stage 1 disease, we're trying to de-escalate. You could argue should be used TILs for that, but we're also looking at chemo-free options. We're running at the moment an interesting trial with the WSG, where we give an antibody drug conjugate alone or with pembrolizumab in this setting, and will be interesting to see what the outcome is. Stage 2, stage 3 disease, there's again lots going on. I often get the question, can we de-escalate immune therapy, which is fine. I'm actually much more interested personally in de-escalating chemotherapy with the help of immune therapy. We struggle to identify optimal responders. The trials we're doing, the trials that are ongoing, are looking at, do we need another 6 months of immune therapy in patients who have apathia? That's an important question to ask. It won't cure an extra patient. Not a single patient will be cured, whether we give through those trials. But of course, it will save a lot of resources, which is critically important. At the moment, I would give adjuvant immune therapy, but if those trial data show there's no benefit, then of course, we do not need to do this anymore. The biggest clinical need, and this is where we make a difference in the future, is patients with residual disease. This is where our focus needs to go, because the outcome of those patients is still not where it should be. I have a lot of hope in the antibody drug conjugates. You know the ongoing studies, ASCENT-5, TROPION-Breast03, a TRAFUSE trial, and I think what really excites me about the ADCs is the high response rate. You see response rates that are 2, 3, 4, sometimes 7 times higher than standard chemotherapy in the metastatic setting. If you now bring that better response rate into an early disease setting, I think those trials will be positive and change what we do. And then we are at the moment working on a de-escalation concept. Again, we are starting a randomized trial with the WSG, where patients with smaller stage 2 TNBCs, where if they have a complete imaging response after 12 weeks, where we try and bring surgery forward, so de-escalation of chemotherapy in that setting. But also in those patients who have residual disease, you're not responding quite as quick as we want to, bringing the ADC in before surgery together with immune therapy, because there's a very exciting interaction. It's the ADAPT TN4 trial. So this is where we are with triple-negative breast cancer. We've come a long way. Immune therapy, pembrolizumab, is standard of care and should be offered pretty much to all patients with stage 2 and stage 3 disease. but there are quite a few questions open, and we are keen to work on them to continue to improve outcomes for patients. Thank you very much.
Thank you very much, sir, for your excellent and wonderful presentation.